Hello, everyone, and welcome. We are going to get started in just about 30 seconds. Hello, everyone. Thank you for being here. We are going to get started in just about 10 seconds to give people a chance to log on and get their audio situated. All right. Good afternoon, and welcome to the Indiana Youth Institute's webinar, Partnering with Families to Address the Youth Mental Health Crisis. My name is Joshua Long. I am the Senior Educational Content Manager here at IYI. And we thank you for joining us for today's webinar. We are grateful to have the chance to connect as a community of Indiana youth workers who remain committed to meeting the needs of our youth and children. For those who are not familiar with IYI, our mission is to improve the lives of all Indiana children by strengthening and connecting the people, organizations, and communities that are focused on kids and youth. Listed here, you can see our vision that drives the work that we do for Indiana youth. And before we begin, I'm going to share a few pointers that will help you engage today. For any technical support issues, use the chat feature to send a message, and I or another IYI team member will assist you. Use this feature to converse with the group as well. And so just to practice that, if we could all just go into the chat and introduce ourselves, our name, and the organization that we work for. In addition to the chat, we also encourage you to ask questions. So please use the Q&A feature for any you may have, and we will get to as many as possible. Feel free to also upvote great questions to the top. Later today, you will receive an email with a link to complete an evaluation of this webinar, as well as the presentation slides. Please take a few minutes to let us know your thoughts about today's presentation, and if you don't receive the evaluation email, check your junk as it may have been directed there. Once you complete the evaluation, you will be redirected to your certificate of participation. Like all of IYI's webinars, today's webinar will be posted on our website if you'd like to revisit a portion later or share the opportunity to listen in with partners. And with that, I'm going to turn it over to our speakers, Dr. Jessica Schleider and Jay Chaudhary. I think Jay is going first, so Jay, I will turn it over to you. You're muted, Jay.
Great start. All right. Hey everybody. Hey, thanks, Josh. Great to be here. Happy tax day to everyone who celebrates, which is everyone. We're gonna spend some time today doing an audit of our conceptions about parental consent for mental health, and hopefully we'll gain some knowledge about this really complicated issue. Thrilled to be co-presenting with Dr. Schleider, who I'm a big fan of, and I think has some really compelling research that she will present towards the back half of our conversation today. So what we're going to do, just so folks know what to expect, is I'm going to set the stage a little bit, frame the conversation. Jessica's going to come in with some of her research, but our goal is for this to be somewhat collaborative and conversational. And so please feel free to bombard the question and answer function during this conversation. The one that's not speaking will be monitoring it, and I know Josh will be looking too. So we hope to have some good questions in there. So let's start. I think kind of about like why this conversation is so hard and why it matters so much right now. Like, I mean, we're all on this call. We all because I think at some level we have been experiencing what's commonly referred to as the youth mental health crisis. I don't love the crisis framing personally. I think it takes a lot of agency away from and kind of flattens really complicated situations into a bit of a caricature. But I think regardless of what you call it, we all are aware of the rising need for mental health supports for our youth, as well as the increasingly constrained supply of those services. And so there's been, as you can imagine, with a problem that permeates every level of society, there's been a whole bunch of different policy responses and conversations in regard to this. There's things like, how do you increase the workforce? How do you improve quality? How do you get creative about delivering services in ways that meet youth where they are, and recognize the reality of sort of scarcity and limitations of that supply, and those are all really important conversations. Today we're going to focus on a really important but also pretty narrow piece of the policy conversation, which is, how do you navigate the issue of bringing parents and families into youth mental health care? And this is one of those issues where the truth is everybody is a little bit right, and a little bit, maybe could use some other perspectives, and it's also a little bit uncomfortable. I mean, the core question, and we'll get into some of these in more detail here, but how do we balance the fundamental role of families, with the reality that sometimes they can be barriers to care, right? And so I look, I'm a recovering lawyer, so I'm going to get legal for a minute here. I will do my best to not get bogged down in the minutia of case laws and statutes, but I think it's a really important place to start, because many folks don't know that, like, parenting and the right to determine um, most aspects of your child's life is a fundamental constitutional right. Now, it's not listed in the Constitution. Like, there's a handful of rights that are listed in the Constitution. Those are called enumerated rights. Um, and then the rest of the rights that we enjoy as citizens are derived from the court's interpretation of the Constitution. And there was a Supreme Court case called Troxel v. Granville. We don't need to know anything about that other than it's a Supreme Court case, U.S. Supreme Court case, and it established parental authority as a deeply, deeply protected right, like almost on the level of those enumerated rights, right? So you think of freedom of speech, freedom of religion, those sorts of things. The right to parent is almost at as high a level into as those rights. And so, what does that mean? That means that, for our purpose, it means a lot of things. It means, the right to sort of control your child's religion. It means the right to do a whole lot of stand in the shoes of your child until they're attain the age of minority in a majority in a whole bunch of ways. For our practical purposes, it means that parents are the default legal decision makers for children. That is the default. That is how it happens. And one of the areas that it becomes most relevant is in medical care. It's not an absolute right. There's a complicated body of law on issues like parents denying medical care for youth because of religion, and I mean, generally it falls on towards the idea that parents can't deny life-saving medical care, for their children, or at the very least there's limitations on how they can do that. I'm not going to go into any of that there. um, but the reason I bring up the exceptions, or the fact that this is not absolute, is because what we're talking about right now is basically like the default is parents decide. There's exceptions to that, and the conversation today is like, where does youth mental health fall into those exceptions, right? Obviously parents matter. The question is when and how those exceptions should exist. And I think it's really important to say, and this will be a common refrain with both me and Jessica, that, like, we're talking about edge cases here. Like, the vast majority of families seeking help for youth mental health care are doing so as families, with a parent and child team. Oftentimes, the parent is the one pushing, and so these are not, like, the conversations we're talking about here, to a certain extent, are edge cases, like situations where the child, is desiring mental health care, and the parent, for whatever reason, may be resistant or standing in the way. But they are cases, and they're cases that matter. And as Jessica will show in a bit, they're cases that matter a lot. Um, so as we think about the policy landscape here, obviously this is an Indiana-focused presentation, but it's important, I think, to zoom out and understand these laws operate on a spectrum. Like, on one end of the spectrum is what's called strict opt-in, where explicit parental consent is required before any kind of care, and sometimes even for each service, or each sort of or each type of service. The other end of the spectrum is the youth autonomy models, where it's, youth generally, over there's a certain age, usually like 14, sometimes can, um, it essentially lowers the age of consent, and sort of doesn't even have like disclosure requirements to parents. And then there's everything in between, where there's other age-based thresholds. There's opt-out consents, which are so people don't understand sometimes that opt-in and opt-out is one of the single most powerful behavioral nudges that you can give. And so opt in means parents have to opt in. Opt out means you're going to disclose, school will disclose, or the provider will disclose, and then the parent will be able to opt in or opt out. In Indiana, where we are right now, we're pretty close to the end of the opt-in spectrum, although not quite. There's a bit of nuance there, and there's some exceptions for crisis care, et cetera. But this is not a legal presentation, so don't take any of this, as legal advice. I have to say, most states live in the messy middle, and even the strictest states, like I said, like Indiana, have exceptions for emergencies. Um, the last point I wanted to make, before turning it over to Jessica, is like a lot of our discourse. These conversations often devolve into unrecognizable straw men or caricatures on either side, right? Like, people that are using the issue of youth mental health to score political points. On either side, we'll bring up edge cases and say, like, oftentimes we'll bring up things like LGBTQ issues, or different versions of that, and suggest that there's some sort of sinister agenda on behalf of schools, or mental health care professionals that want to take your kids away from you, or they want to interfere with your parental relationship. And then on the other side, there's, I think, equal caricatures of, these people they want to see kids, kill themselves, right? And of course we know that's not how the real world actually operates, but that is how the discourse often operates. And I think, like, before we jump into to Jessica's research, I wanted to kind of like, um, unpack this idea of like why people could object to giving youth more autonomy, because I think, as you'll find, ultimately both Jessica and I err on that side of giving youth more autonomy. But I think it's important to understand the opposition to that. And so we talked about it before. I mean, there's this idea that like family is the fundamental unit of society, and this is not like an ideological. This is sort of a structural thing. Like, we all belong in families, whether they're chosen or found or biological or nuclear or whatever form they make. Like, the point of having a family is you have moral, social, financial, and legal responsibilities to each other, and those legal responsibilities matter. One of the reasons why the push for same-sex marriage was so profound was the recognition that those legal relationships really, really do matter, because they signal like societal value, and recognition and validation of that relationship. And so when you're a parent, part of that is like you're a default decision maker for your child. And I know personally, as a parent, I want to know what's going on in my child's life, and it's really, really frightening and potentially threatening, if that relationship is called into question in any way, shape, or form. And I think we just have to like validate that as like a really important viewpoint. And before we get to Jessica, like, are there reasons? The fundamental question is, are there reasons, and what does the data and research say about like treating mental health differently from other medical care? And what are the lines that we draw there? So, that's the frame. Hopefully it was useful. Feel free to throw questions in there before we turn. And now I will turn it over to Jessica to talk about her research on the topic.
Thanks so much, Jay. I think that really does provide wonderful context for the complexity of this conversation. Hi, everybody. I'm really excited to be with you to discuss this tricky and critical issue with you today. By way of introduction, I'm Jessica Schleider. I'm trained as a clinical child and adolescent psychologist. I'm an associate professor at Northwestern, where I direct the Lab for Scalable Mental Health. And I'm speaking to this issue as from the perspective both as a trained clinician for youth and families, but also as someone who cares deeply, and it pretty much, my life's work is trying to figure out how to make mental health care more accessible to young people and families who need it. The reality in our country right now is that 80% of young people who need mental health care do not access anything at all. So we really need to band together as mental health providers, professionals, researchers, legal experts, policy experts to figure out how to make that a reality. The issue of parental consent policies and laws in youth access to care is not something that I initially thought about. It was actually our experience in the lab and trying to scale brief and online interventions to young people that made this issue pretty impossible for me to ignore. And as such, it's become really a central focus of how we think about designing and disseminating evidence-based supports for young people, and how to address barriers in access to treatment for youth. So, zooming back, a decade or so, I was conducting clinical trials research and delivering these resources that we were creating, these brief, our lab study single session interventions, largely requiring parental consent for youth to take part in them, which was the status quo. It was what I was trained to do. It was what I was expected to do. But what we started seeing is that what requiring parental consent did is it led to pretty skewed populations actually reaching the care that we were providing. Upper middle class families, white families, families who already had access to other forms of treatment. These were primarily the folks that we were reaching. And, we started to reflect on in conversations with others in the field, what would it be like if we offered youth the opportunity to say themselves whether or not they wanted to reach out for support? And after discussing with our university ethics board and actually getting approvals and waivers to offer brief digital online tools for mental health directly to young people, we started doing clinical trials with these waivers. And what we saw was that all of a sudden, half of our samples were racial or ethnic minority young people. The vast majority were reporting all of these adversities and complexities that did not show up at all in populations that we were previously reaching. 80% of our samples became sexual and gender minority young people seeking support and services. We were reaching a completely different subset of youth simply by taking that parental consent requirement and removing it. It was really striking and so disparate from the rest of the youth mental health literature and treatment seeking patterns in the country. So this led us to wonder what was getting in the way for these young people in accessing other kinds of support if they were showing up in this form of support provision, but not others. And we started conducting research, qualitative and mixed methods research, asking tons of teens who'd experienced barriers to accessing treatment and who had lived experience of depression. What got in the way for you? We've published now 2 papers in the Journal of Adolescent Health and the other in the Journal of Research on Adolescence, interviewing hundreds of adolescents who've experienced this. And what we found was, in the other literature on this topic, the barriers that come up most frequently per parent reports are things like finances and travel and logistics. Those are the reasons why barriers to care exist. But if you ask teens who haven't been able to access care, 32 to 42% say the biggest barrier to accessing treatment when I needed it was my parents. That's not because, and the teens are very upfront about this, not necessarily because parents were explicitly saying, no, you can't access treatment, or saying there's no such thing as depression, although that did come up for some. What we were finding was that a lot of adolescents just didn't want to disclose and burden their families with this information. They knew that treatment was expensive and costly, and that they knew that their families were already experiencing considerable stress. So in addition to fears about invalidation from self-disclosure, what they were sharing was that they didn't want to share that burden with their parents. And as a result, they couldn't access care because their parents were required. They were mandatory participants in that pathway to treatment. This was really striking to us and caused us to wonder, how do state policies factor into this? How do policies around access to treatment actually impact this at a population level? So a couple of years ago, our lab conducted what's called a legal mapping study. We coded all of the state policies and laws in the country across all 50 states based on how strict they were with respect to that spectrum that Jay was talking about earlier. Are adolescents in any circumstances allowed to self-refer to mental health care at the state level? Or are parents always required, no matter what, for active consent? And what we found was that, and the laws in Indiana are some of the strictest, but what we found was that, first of all, about a third of states do not allow adolescents to independently access any kind of mental health support without parental involvement. And the pattern that we saw when we were looking at national access patterns to treatment was really striking. What we found was that treatment access among adolescents with past year depression was about 9 percentage points lower in states that mandate caregiver consent for professional mental health services compared to states that don't. At the population level. So what that means is that in states that do allow parental minor independent consent to mental health services, about 46% of adolescents with depression are accessing treatment. That's still really low because of all the other barriers that exist. But in states that require parental consent for adolescents to access treatment, only 37% are accessing any treatment. So that's one policy associated with a 9 percentage points difference at the population level. Jay was discussing that, these are edge cases that we're talking about. I actually would argue that they aren't, because the families we see where the families are together seeking support, those are the families who make it to the front door of the clinic. Those are the families who get through all the other barriers and show up to us for help. What we're missing is the 80% of families and adolescents who don't. And taking those folks into account, what we see is that laws around parental consent requirements have a major impact, an outsized impact, I would argue, on access to treatment. So no matter how scalable, no matter how accessible we build our interventions in mental health for youth to be, they will fail to actually make a dent in population mental health if we don't attend to these sort of structural factors. And this is all to say that I don't think the solution alone is just allow adolescents in all cases to access treatment independently, no matter what. That's not the argument. But what I do think is that we need a more nuanced conversation that addresses, when and why parents might inadvertently become barriers to help seeking, especially in those early stages. And how can we create systems that address upstream the problems that may become barriers down the road, rather than just, sort of overprotecting, overcorrecting and saying they have to be involved every time. So I think part of the solution has to be facilitating conversations with families when and in those circumstances where youth are coming forward and saying, I'm worried about disclosing. But in order for that to happen, there have to be youth-directed on-ramps to that initial disclosure that don't immediately cause them to retreat and keep this secret. So yeah, I think it's a really major set of decision points that it's really important for clinicians and youth-serving folks to be sensitive to, and it's really, really tricky. But the bottom line is it's not something that we can ignore, and really has to be an ongoing part of the conversation about access to care.
Great. Well, Jessica, there's a question from the audience that I think is really, really good question and brings up. So the question is about immigrants, and I think that's a really, really important and unfortunate currently illustration of the point you're making. I think we all are aware of the climate right now for immigrants and undocumented folks and people who might be seen as as undocumented, whether or not they actually are, right? And so I've heard anecdotally a ton of stories, kind of across the board in a bunch of different domains, like with school services in general, or access to coming to youth serving programs, of immigrant families really pulling back from like overall participation in society. So I'm wondering if you can comment on that at all, or if, I mean, this kind of came after your research, but that's something that I'm thinking a lot about, and it sounds like the audience is as well.
Oh, 100%. And, in families dealing with immigration related stress, the stress of being even sort of accused of being undocumented in this climate, whether or not, as you were saying, Jay, it's reflective of reality. Those are families where worries about burdening parents can be especially intense. Um, if if a family is already existing in a universe that it feels actively dangerous. It feels like you can't say the wrong thing to the wrong person, or you're risking being separated from your family. Why on earth would a teenager want to add risk to that pile? Um, so that I think really reflects strongly on when there are families who are under structural strain, discrimination. Those are the families where this desire for adolescents to protect their caregivers from additional stress or worry may be especially strong. It's also the case that there are major cultural differences in how families' willingness to talk about mental health support shows up. And in a lot of families, first generation kids, they're talking to us in interview contexts very much about, this isn't something that we discuss in my family. It's just not a topic that comes up. And therefore there's no language to talk about it. There's no way to broach this topic in a way that would make sense. So I just don't. And so I think there are a lot of unique issues in that dynamic that and in this present moment that make this issue in immigrant families particularly challenging.
Yeah, absolutely. And so again, keep those audience questions coming, but I'm going to keep peppering Jessica with questions of my own until I see some other ones there. And I'm going to pivot a little bit. I know, Jessica, we are not we did not plan on talking about your, can I call it your day job, right? About about single session interventions, but as we're having this conversation now, I do wonder if you have thoughts on, well, let me back up. So, I mean, I'll have Jessica explain single session consultations. And Alice, I will get to your question in a second here. Thank you for the question. Um, when it comes to your research on single session interventions consultations, like I always think like, uh, accessing mental health care can be very just both traumatizing and annoying because of the way our systems are set up. Like it feels like you're, as somebody trying to access care, wow, I got to commit to like several sessions of an hour and talking about. And so like I'm wondering if you think that even though these are in some ways two separate lines of research for you, the single sessions and the parental consent piece, if there's some interlap, like if we made
Yeah.
mental health care less intimidating, do we think some of the parental consent questions might be addressed as well? And so maybe explain what
Yeah.
SSIs are quickly, and then go to that.
Yeah. So I don't see them as totally disparate, actually. And I see them as increasingly connected because of work that we're writing up for publication now on adolescents' perspectives on these policies and laws, and how they differ depending on the type of treatment being provided. So just for a little bit of context, my lab studies single session mental health interventions, which are structured programs or supports that are designed to make some kind of clinical impact within one encounter. Knowing that a lot of the time, one encounter is all you're going to get with a young person. And why are we not optimizing our treatments to make that moment matter? So, we study this idea and create interventions and test them and scale them in various ways with various communities, including in Indiana with multiple partners. So it's interesting because I think that the issue of parental consent requirements in mental health care, I think the conversation has to be contingent on what level of care and urgency and intensity are we talking about in treatment. Requiring parental consent to inpatient care is very different than requiring parental consent to an online self-guided tool. Or like, imagine if parental consent were required for teens to pick up a self-help book, right? That would be kind of absurd. Like they can't check a book out of although in some cases they can't check a book out of a library.
Yeah, let's not go down that rabbit.
Yeah, so maybe that's less absurd than I'm saying. But there are gradations of this, and for versions of treatment for mental health support that are designed for low barrier to entry, early stages of help seeking, that are known to be safe and effective, allowing some autonomy to young people in those cases, to me, that makes more common sense than allowing youth to check into a hospital without their parents know. Nor would it be like logistically or practically possible for that to even happen because of insurance and all these things, payments. So I think those are really tightly intertwined issues, but in broad discussions of like what the policy should be, should parents be required or not to provide consent, we tend to flatten what mental health care actually is.
That's right.
And collapse all forms of support into one unified construct when there's so many different kinds of resources and supports out there, as there should be, because there need to be multiple on-ramps for youth to access help in the earliest stages. So I really wish for a future where policy is more nuanced and addresses the complexity of the mental health support ecosystem, not just the complexity of the parental consent question.
That's right.
Yeah.
Well, and then that's a great lead in, I think, to Alice's question, which if you were to craft a question in a lab to address some of the complexities implicated here, this would probably be the one. So, thank you, Alice, for the question. And also, thanks a lot, Alice, for this question, because and the question for folks that can't see it is, how can mental health professionals ethically, legally, and effectively advocate for a child's need for care when parental beliefs are in direct conflict, particularly when one parent dismisses symptoms as attention seeking while the other recognizes legitimate mental health concern? And first of all, wow, that happens all the time. I don't want to dismiss it. I've seen it as a lawyer way back when I was practicing. Have to disclaim, I'm not giving you legal advice here, because, and nor could I really, even if I wanted to, because there's a cat there, because these are such fact and situation specific circumstances that it's hard to say. But I think that what Jessica was talking about before, I'm wondering if that might be, which and just to kind of sum it up, just so people know what I'm talking about here, low barrier, sort of low intensity, less sort of invasive feeling interventions. Is it possible that starting there could be a way into getting the parent who is less enthusiastic about mental health care as a way in to sort of explaining that might be something. The other thing, Jessica, you say something about that maybe? So.
Yeah, I actually think that the single session approach can potentially be useful here too, because what a one at a time approach to offering services allows you to say to families or help seekers is, look, we're not saying you need to do this forever. Let's give it one try. Let's see what we can do in one session without the commitment of long-term care, kind of as an experiment. Is it even possible to make a meaningful change that could be helpful to anybody, not just somebody with or without a diagnosis? And we can take it from there. And so, I think that another one benefit of a one at a time or single session approach is that people can kind of dip their toe in. You can lean into that hesitancy, or uncertainty around whether this is necessary or whether it can even be helpful. You can avoid some of the stigma associated with seeking out long-term treatment, but you can offer people something evidence-based as opposed to nothing at all. So sometimes folks who are in the very early stages of help seeking or even themselves have self-stigma and are worried what entering therapy says about them. The single session approach can be it can be more approachable, basically.
That's right.
So in these contexts where families have a sort of resistant party, that offering can be useful for sure.
That's right. And just so folks know, you don't need to have anything other than an internet connection right now to access some of these self-guided single session evidence-based interventions, through this project called Project Yes, right, which Jessica's lab has been pioneering. Where can maybe you can put that in the chat so folks can access that, because I think it's really important. To kind of build on Alice's question as well, there's another approach that I've been learning more about, which I'm not an expert on this really, but I've been learning more about, which is the idea of family mental health. And there's some models that are and modalities and platforms that are popping up around this idea, and it really stems from the idea that actually there's actually three patients in any youth mental health situation. Like there's the child, there's the parents, and then there's the relationship between the two, like that. And so these interventions. So there's different models, different modalities. There's not a whole lot necessarily in Indiana, but we're working to bring some of these models here. And so I think advocating for family approaches where you treat the family as unit of intervention as opposed to any of the individuals, I think are really promising as well. So, looks like Esther. Hey, Esther, it's good to see you. Has a question here. Have you found that parents and youth are more open to individual therapy instead of group conversations? So that is a good question. I don't know, Jessica, if you have any thoughts on it.
I'm not sure about the context exactly. So sometimes, but group conversation sorts about mental health, it's possible that there's a difference there. That's not something we've studied in detail. But certainly there are families who, especially when stigma or fear of judgment from others is really strong, where a group conversation would pretty much be a non-starter.
Well, let me take this in a slightly different conversation, because I'll share from my family's experience. I have some mental health issues in my family, and I remember, and my parents are Indian immigrants, obviously, and I think there was this sense, like I don't know if I want to call it a stereotype, but I think there's this sense out there in like pop culture and in the world that like therapy is all about figuring out what your parents did to mess you up, right? That is pervasively out there. Like I'm probably dating myself. You think about The Sopranos, for example, like most of the conversations between Tony Soprano and his therapist on that show are about all usually end with something about Tony's mother, right? And I don't really have an answer there, other than I think culturally, like I think that is something, because I think that gets to what Esther was asking here, which is like, okay, let's see. Here we go. All right, now here's an explanation. Esther's asking because they've had having conversations in the barbershop with young men and mental health professionals. I was wondering if that came up in your study. Yeah, I think again the point here is that there's no one size fits all approach, which is why I do think things like SSIs and family mental health approaches are allow for a whole bunch of different kind of conversations. I think where you might get into trouble, and maybe Esther, you've seen this with your barbershop program, like if there's only one rigid kind of on ramp, to use Jessica's words, of like, okay, we identified an issue in the barbershop. Now we're going to make this referral to the local community mental health center. for, this type of therapy, like every the more rigid it gets, the more likely it is folks are going to choose not to continue on that off ramp. And so I think like the answer, there's no answer here, but the what we're suggesting, I think high level in this conversation is that there's multiple kind of pathways um, for care, and that our job as people that are kind of building the system are to create as many easy on ramps as possible. And that's where I think anything that blockades on ramps, to bring us back to the beginning of the conversation, such as parental consent laws that are really onerous, are things we should look at with some skepticism. I actually think the Esther's Barbershop project, which is in Northwest Indiana. Well, yeah, no, I mean, Megan, you were. This is. I'm so glad you asked that. This is not a different webinar. Um, the structural. So Megan is saying family mental health is something social workers have been trying for years. Have been trying to treat the children-parent relationships. Insurance only pays for 45-minute sessions and pays less than if you were seeing an individual. This is actually exactly the point, right, of all of this stuff, which is that structural factors. And so we were talking about parental consent laws as one structural factor. The incentives and setup of reimbursement for is so designed through sort of like this individual lens. So some, for example, some states have what's called dyadic billing, where they will allow you to bill for the parent, or usually it's the mom and the baby, but the parent and child unit as a unit, and it's in parity with what you would get if it was a 45-minute individual session, for example. And so there are structural factors that have kept family mental health from being implemented in places like Indiana. There are actually answers to these that are being done other places. That I think part of what we have to do as a community is educate and advocate for those to come here, because right now they aren't. I don't know, Jessica, you have any thoughts on that? I know you have many thoughts on the reimbursement structure, but
I don't think I have thoughts that would extend what you just said.
right,
Yeah.
right. But yeah, great question, Megan. This is exactly right, and you're absolutely right to point out that regardless of how folks want to practice, how we're actually able to practice is almost completely dictated by structures that are not built with the best interests of children and families in mind.
I have a question, a little bit of a comment. I'm thinking about folks that maybe have limited interaction with parents, such as like coaches, after school workers, etc. Dr. Slatter, I'm thinking about what you said about single session interventions with parents. And I'm just wondering if I'm an after school worker, if I'm a coach and I'm noticing something and I only have, say, 20 minutes with a parent, what recommendations would you have as far as like what you should be saying to them, how you should be saying it, sort of thing?
Yeah, so there are a couple of angles I think to go with this kind of situation. One is, in these situations, coaches, teachers, youth mentors, they're going to be primarily interfacing with the young people, offering them free anonymous resources directly, like but not limited to those single session online tools, which can be accessed for free anonymously by anybody, anywhere, anytime. That's one avenue to getting youth support right away. But introducing these tools to parents as well could be a starting point. So if a parent is unsure how to talk about this with their child, or unsure where to start or where to reference or refer their kid, beyond just trying sometimes to no avail to find an available therapist who takes their insurance and doesn't have a 6-month waiting list, that can be a starting point. So I think a lot of parents are really hesitant to talk about these things because they worry that talking about mental health concerns will create them or bringing up the idea of suicide or, self-harm or something risky will somehow increase the likelihood of their child experiencing that thing, which the data says is not true, but it certainly can be a barrier to parents broaching the subject. with their children. So I think from the perspective of a coach or a teacher or a youth mentor, simply saying that, it's actually okay and safe to have these conversations. If you want to have them in a structured way, there are tools you can look at maybe together with your child, that can guide you through thinking about different ways of coping, with different types of stressors. And so, one question come in. What are the hours that kids can connect with online single sessions? Anytime, because they do not have a therapist involved. They are self-guided online tools. I dropped the link to all of them for free, in the chat. You can use them, you can share them, whatever you want to do. They are there for you and for teens. But there is no hour limit. You can use them anywhere, anytime. So what I would say is coaches and folks in those kinds of situations can urge the beginnings of conversations and maybe jointly guiding those conversations around evidence-based tools so that parents don't have to be worried about not knowing what to say.
That's great. There's a great question in the chat, which I'm so glad this was asked. It's about wondering about faith organizations. There is some guidance for schools and suicide prevention and mental health, but what about faith groups that host before and after programs, athletic groups, and school vacation retreats? How do we work with them regarding seeking mental health support for youth when surrounded by stigma? And I love this question because this has come up a ton over the last several months, just kind of in my world randomly. Like there are a lot of faith organizations that are interested in helping out, and I think the answer is not necessarily about specific trainings or about specific resources, although those are really important too. The answer is about something much more fundamental, which is respect, right? Like in order to have these conversations, like we have to understand that like faith and mental health care, mental health support are not mutually exclusive, and like they can be self-reinforcing, but that requires bi-directional sort of respect. Like it can't just be like as mental health care advocates or professionals, like we can't dismiss the importance of the faith aspect. It's sort of, and how this is not my quote, I wish it was, but how a pastor, I was on a panel with put it was, it's not about getting rid of Jesus, right? It's about Jesus and the mental health care, right? Not as opposed. And so, I mean, I think the best thing we can do is catalyze, and I think we're pretty close to this, but I think there's like a peer-to-peer between faith organizations that will be much more effective than anything else. Like can we create like this learning collaborative, and I think that we're close and would love to talk offline maybe about how we can do that, but a learning collaborative between faith organizations about mental health care, because the truth is like a lot of folks I meet and who are in recovery from addiction or have been able to successfully address significant mental health challenges, faith played a really big part in that, and but it was faith plus evidence-based treatment, plus family support, plus community. It's like all of these things. We can't divorce this really complicated thing from the context in which it develops. And so great question. Would love to have a conversation about how to catalyze some sort of peer-to-peer learning between faith organizations. Anything to add, Jessica? Do you have an SSI for faith yet or not? I mean, I feel you have SSIs for everything. I was wondering if you had one.
No. However, in a community advisory board meeting for a project of disseminating SSIs in St. Joseph County the other day, we did have a faith leader on our community advisory board, and was echoing all of these points about the importance of leveraging these spaces where people already go naturalistically for help and support and community for delivery of these kinds of, brief, low intensity support. So I think that not necessarily targeting faith-related outcomes in an SSI, but equipping leaders in these communities to provide those supports in the context of, a faith-based community, I think could be pretty powerful.
That's right. Well, and Alice says here that faith folks are trained theologically,
yeah,
not mental health, and I think that's true, right? But I also think at least from what I mean, and this is a selection bias thing because they wouldn't come to me if they weren't already oriented this way. But I just had a ton of outreach from faith groups who are saying, look, like this is something we are seeing every single day in our community, our congregations. Like even though we're not mental health professionals, like can our how do we equip our pastors and lay leaders with the tools to
Yeah.
be able to help? And it can't just be like find a clinician referral process. And that's where I think a lot of the faith folks I've talked to got into this thinking they would just do that, like they would just literally set up a referral process. And I think what they're finding is that is number one because of the structural issues you talked about, the waiting lists and the scarcity, but it also doesn't address the whole person. Like
Right.
and so how do we instead? Yeah, your thoughts on that?
And not everything therapeutic is therapy. So, there can be resources and avenues to equipping faith-based leaders, even if they're not trained as mental health clinicians, with tools and strategies that are known to be deliverable by non-professionals. So there are evidence-based mental health supports that are by design built so that anybody can deliver them. Peers, lay providers, non-mental health trained folks. We've trained hundreds of nursing students, um, peers to deliver single session consultations, um, precisely for that reason, because the mental health care crisis is not going to be solved purely by traditional providers who have licenses and uh, can deliver therapy. So
And
I think
if
it's
I can
possible to go in that direction, but it's going to take a rethinking of like what does mental health support look like and who can provide useful touch points in that space.
Yeah, and if I can add to that too, outside of just the faith community, our athletic coaches are not necessarily trained in mental health, but like for a swim team, for example, that might be who a child is seeing the most during the day. And
Exactly.
so I think as we think about our youth workers and the benefits of single session intervention, whether it's with kids or with parents, I think it's important to look at what are the touch points of like who is a child interacting with on a daily basis, who are the influences, and are those people trained? Do they have the tools? Like bus drivers, for example. Like bus drivers see kids every day. Do they have the tools to be able to address this? So
That's right. I mean, I think that's sort of how do you make every place youth interact with sort of fluent in not only the language but also the practices that promote positive mental health.
especially because as more of the adults and youth workers that work with kids are on the same page regarding that, I think that also helps with the parent sort of aspect of this. If everyone's on the same page and are helping parents understand and educate in the same way, then that messaging could help them, be more open to mental health services.
That's right. All right, I got time for one more question, or we can move on to kind of closing thoughts. If
We
Jessica,
got time for one more if anyone has one.
okay. They also can't believe that this is a comment from Alice. I think is really good. There's like they can't also believe. I think we're talking about faith leaders that this is a knock of them not meeting the needs of parishioners. Just like someone who has cancer, you'd always hear I could use the prayers, and they go to health professionals for actual care. But clergy encourages prayers. Chemo and radiation can only do so much. Prayer helps getting over the line to remission. And this is where, and this is maybe a controversial statement, but I'm going to preface like I actually this is where I think the idea that like, mental health is health, which is the statement that like is often made, like is true, but also like woefully incomplete. Like I think that um like mental health is not like cancer. There are elements of the mental health, especially the clinical system, that should be in parity with the clinical elements of cancer treatment. But then there's elements of like community and connection and purpose and service, and those are all primary inputs to mental health, not secondary, not tertiary. Like they are primary inputs to mental health. And I think that, in Dallas, that's the point. Like the point of busting stigma is not to make mental health just like all other health. The point of busting stigma is to make mental health more socially accepted so that people who are suffering in silence can access things like community and connection and purpose and service and all of those other things. Um, and so that's right. And so I think that's a really kind of good place to maybe end, which, and on a, for me at least, like I think like that we have to start treating mental health as a common good that we're all responsible for cultivating, as opposed to something that only happens in clinical settings or only happens in the 50 minutes in a therapist's office, versus like something that happens everywhere and that we're all responsible for. So
And I think that can
Jessica.
also be an empowering frame for caregivers to know that it's not just formal treatment systems and connection with these high intensity services that can promote youth well-being and positive outcomes, but they have the ability to really direct these outcomes as well as the folks that their children interact with every day. So I think treating this as a communal shared responsibility and opportunity rather than just like a sort of a gate kept thing that happens in these specialized spaces can only be a benefit.
Right. Let me just Josh, real quick. There's a couple things in the in
Yeah.
the in the question Q&A. I think somebody comments there's some adults that are fearful of saying the wrong thing. I think that's absolutely
Yeah.
something we should respect and understand and try to deal with compassion. I think there's a lot of just fear, and I think it's reasonable and rational, especially sometimes you're dealing with life, like literal life or death. That's why I think that's completely understandable. I think part of it's all in all of us to become more fluid in this language and practices. um, Esther, I'm not sure which study you're talking about, but we can sure figure out maybe offline what that is. And a final comment, which is about individualism versus collectivism, will be concepts we must address to bring adults like bus driver, like the understanding this is all our responsibility is something that will take some work and conversation into getting into the culture. But I think um, the flip side of this being a crisis that's everywhere is that it's a crisis that's everywhere. It affects everybody, which means people are a little bit maybe more on board to do their part. So great, Esther, reach out to us offline. We'll be sure to get you those studies. So, and most everything is on your lab website, right, Jessica?
Yep.
The lab for scalable mental health.
Yeah.
Great. Dr. Schleider, Jay, any final thoughts, or are you guys good to go? Great. Well, with that, thank you. Thank you so much for that incredibly insightful webinar. As we finish up in the last few minutes here, I'm going to bring a few events to your attention. The first, so for those of you that were interested in SSIs or single session interventions, Dr. Schleider will be presenting on that at our National Summit on Youth Wellbeing, which is scheduled for May 5th, 2026. Which is virtual. So please join us for that. It's a national gathering that brings together youth-serving professionals, organizational leaders, and community partners who are committed to strengthening the systems and supports that help young people thrive. So please consider attending that. Additionally, next month, our webinar is Healthy Youth Sport, Foundation for Thriving Communities. That's on May 20th, 2026. And then finally, the best way to get updates from different education trainings and organizational capacity opportunities is to subscribe to our weekly newsletter. It is a quick read once a week, and it'll give you all of the information that you need. As we conclude today, I one more time just want to sincerely thank you for being here with us. We appreciate your impact, your voice, and your choice to learn and partner with IYI. This afternoon, you will receive an email that will include a copy of these slides so you can get the information on the events, as well as a link to complete the evaluation of this webinar. Please take a few minutes to let us know what you thought about today's webinar, and upon completion, you will be redirected to your certificate of completion. If you don't receive that evaluation email, check your junk as it may have been directed there. And so with that, I want to once again thank Jay and Dr. Schleider, and that concludes our presentation. Thank you so much for showing up today and every day for Indiana youth.